Welcome to this episode of the Clinical Podcast Series brought to you by the American Academy of Optometry Foundation. On today's episode, we'll be discussing the article entitled Neurotrophic Keratopathy, an Updated Understanding, published in the Journal of the Ocular Surface in 2023. I'm Dr. Kelsy Steele, your host and the topical editor of the Anterior Segment Disease Care, and I am thrilled to be joined today by our topical expert, my friend, Dr. Avani. Dr. Deve is the director of the Optometry and Contact Lens Service at the Ross Eye Institute in the University of Buffalo's Department of Ophthalmology. Her clinical interests include specialty contact lens care, post-operative care, and ocular surface disease. Welcome, Dr. Deve.
Thanks for having me.
Thanks for being here. So to start it off, what was the general purpose of the study? I say study with kind of air quotes because it wasn't really a traditional, methods, results kind of thing, but more like a think tank, a study section. But what was the general purpose of this group getting together?
Absolutely. And I think that really the purpose of this group getting together was to provide a more updated and expanded version of the staging system of neurotrophic keratopathy. What we've had in the past is a very small classification system, mostly with 3 stages. And so what this study or this group really elicited was expanding into 6 different stages that are much more detailed and more in a sequential order of the disease of NK. And in doing so, what this helps providers moving forward is to not only classify the diagnosis, but also then to tailor treatment and management focused based off of the staging system. And I think lastly, the staging system in particular now with this proposed group was to really think about the involvement of the stroma in NK, in addition to also focusing on the epithelium.
Yeah, I think the traditional classification just focused a lot on, SPK and epi defects and didn't really talk a lot about stromal involvement, right?
Exactly. And I think also the prior classification thought about stromal involvement almost in an earlier stage when in sequential order. Oftentimes we see that this happens later on in
Right.
neurotrophic keratopathy.
So kind of bringing it back a little bit, can you give us just a brief definition for maybe some of our listeners who don't manage this condition very much?
Absolutely. So neurotrophic keratopathy, by definition, is the loss of corneal nerve function through the ophthalmic branch of our trigeminal nerves. And so corneal denervation essentially leads to the dysregulation of the epithelium preservation. And this is seen through the loss of neurotrophic factors, as well as your lacrimal system and your blink reflex. And ultimately, this is disrupting the entire ocular surface homeostasis. And when we see this, it leads to epithelium breakdown and ultimately keratolysis.
Yeah, so we know, for those of us that do manage this, that there are a large variety of potential causes and associations. But in your clinical experience, what would you say are typically the most common that you encounter when managing these patients?
Absolutely. 100% it's herpes viral etiology, be it simplex or zoster disease. That's probably about 25% of my clinical practice, given that I focus mostly on anterior segment. And it's become so standardized within my own clinics that our technicians and our workup staff are taught to not instill any anesthetic drops when there's any suspicion of any type of herpes viral etiology. And that provides the physicians an opportunity to check corneal sensitivity.
Yeah.
So I think that's the number one. Now, oftentimes thinking out of the box, especially given I'm working in a specialty contact lens practice, I see a lot of surgical patients. So be it LASIK, PRK, PKP patients. And so oftentimes those patients will also have a loss of denervation given their surgical background. The last 2 categories that I find are also sector of my practice of NK is diabetics, especially the patients that are older that have various blood sugar control. We know that diabetes in general leads to peripheral neuropathy, but oftentimes I'll see these patients stain with no pain, and that's where I'm thinking NK. And lastly, because I work in ophthalmology, I have my glaucoma colleagues just down the road from me. And so oftentimes a lot of these patients are coming in to see me due to their poor ocular surface control. And sometimes while this can be toxicity related, oftentimes a lot of those glaucoma medications, including our beta blockers, can lead to loss of corneal nerve function. So my biggest tell is signs that outweigh symptoms. I'm thinking NK.
Yeah. Yeah. I mean, a lot of times these patients come in and they don't really have very specific complaints. And then you look behind the slit lamp and you're like, whoa, this is not what I was expecting based on your chief complaint.
Right, exactly.
So going back to our paper, so how have the authors proposed to change this classification and system and kind of modernize and update it? And then is numeric staging something that you use in your clinical practice?
Absolutely. So let's first focus on really just defining the stages. So what the authors of the paper really did was expanded it into 6 stages. So when we actually think of stage 1, they propose that it's altered sensation without any keratopathy. So in other words, we're really not seeing any clinical signs whatsoever behind on that slit lamp. Stage 2 is when you develop epitheliopathy. Stage 3 is when it's persistent epithelial defects or recurrent epithelial defects, but the key here is that the stroma is not involved. Stage 4 is when you have the epithelium involved, but now also the stroma, including some haze. Stage 5 is corneal ulceration or thinning, and then stage 6, which is leading eventually to corneal perforation. So personally, I use a numeric staging system across the board for many other conditions, be it glaucoma, be
Mhm.
it levels of diabetic, retinopathy. So the way I see it is when we think about an anterior segment disease like neurotrophic keratopathy, why wouldn't we use the staging
Right.
system? And I use this in my own clinical practice for a variety of reasons. One is it's consolidating a lot of the clinical data I see when it comes to my assessment of the condition. And it allows me to identify the level of disease severity, be able to educate the patient on their staging, but then also be able to recommend the appropriate management or treatments based off of the level of disease or the staging of neurotrophic keratopathy. And ultimately, what I think is helpful, not only in a diagnosis and a management, but also an education tool, is we're able to then have a conversation with the patient about their visual and disease prognosis. And I think this is where having such a detailed and defined staging system is important, not only for our clinical practice, but also for our patient discussion.
Yeah, and to give them some maybe appropriate outcomes that they could potentially look forward to or, manage now before it gets to a certain further stage, right? So
Exactly.
on the topic of treatment, so in this paper, they talk a lot about ocular surface lubrication, which we know is important in most any anterior segment condition. Aside from that, what are your typical go-to treatments for these cases? I'm sure, it's going to range by the staging and the underlying cause, but do you have kind of a specific arsenal that you like to go with?
Right. So I think you took the words right out, which is it's completely dependent on the
Yeah.
staging and the severity of the disease. So outside of course, ocular surface lubrication, which I think is the bare minimum, what I kind of like to think about is direct ways of treating NK and then non-direct ways that are still helping to promote the ocular surface. So in addition to lubricants, my next level is to think about some form of anti-inflammatory therapy, be it topical treatments, so our cyclosporins and our
Yeah.
lifidographs of the world, or also from our eyelid level. So I'm personally employing intense pulse light treatment as well as radio frequency in my clinic to
Okay.
help promote less inflammation on the ocular surface. And that is therefore promoting a healthier and more stable environment. Now, when we think about tear film stability, we also think about improving just the quality of tears, but also the quantity of tears. And
Right.
so that's what I'm thinking about punctal plugs or punctal occlusions. And I work in ophthalmology where I can also then send patients to have punctal cautery
Mhm.
done, as well as Tyrvaya to help improve the tear production levels. Next, I'm thinking about protecting the ocular surface. So we've improved the quality of tears, improved the tear film stability, we're reducing the inflammation, but then how do we protect it? And that's when my contact lenses come out. So we're thinking bandage contact lenses, as well as scleral contact lenses. And I think the beauty of both is creating, be it a thinner or a thicker tear reservoir that creates almost like a microenvironment
Yeah.
that's protecting the epithelium so that the epithelium can really rehabilitate to the best of its ability. And we know that, especially now with scleral lenses, we have the ability of introducing some therapeutics into that tear reservoir as well. So I've oftentimes used that for treatment. Next, amniotic
Yeah.
membranes,
I
be
was
it
gonna ask that next.
dehydrated
Yep.
or cryopreserved.
Mhm.
Personally, I love dehydrated membranes because I find that the retention of it for the patients as well as comfort is better. But of course, we have to, think about the access and the insurance coverage for this. So it's definitely not part of my first line of therapy. I also think about tarsorrhaphies. Patients love them and hate them all at the same time.
Yeah.
Providers love them and hate them at the same time.
Yeah.
I oftentimes will think about even nocturnal tarsorrhaphy, so a tape tarsorrhaphy
Mhm.
versus thinking of sending a patient for a surgical
Right.
lateral tarsorrhaphy. And then really lastly is more direct ways of thinking about how we get that nerve um, stimulation going. And so that's where German or Oxervate comes in. So
Right.
that's an 8-week course, 6 times a day at an interval of 2 hours. And I really use this in the last or end stages of the disease, especially because of the access and requirement of patients to be compliant with this 8-week course.
Yeah.
So you really have to kind of think about who's sitting in your chair and your ability to provide them access to this medication. But when necessary, I've had excellent results after the first 8-week course. I know colleagues, and there's other direct ways of really stimulating nerve growth, including direct neurotization, as well as autologous serum tears. In my clinical practice, it is not necessarily as accessible, especially with the demographic of patients and the community that I have here. But that is definitely something to consider as other ways of really thinking of directly stimulating better nerve growth and corneal innervation.
Wonderful. So to wrap up, do you think, as eye care professionals, is there anything that we should implement or we should take away from the results of this paper? Any changes to our care of patients based on the results?
Absolutely. I think the biggest thing in all of this, before we even get to diagnosing and classifying these patients, is identifying them. So
Yeah.
I think the key is the earlier you diagnose, then you can employ this classification system and the management system and all of our treatment options. And so the number one way to be able to earlier diagnose these patients is checking for corneal sensitivity.
Mm.
And whether you choose to do this, be it in a qualitative measure, using, a con thread or a dental floss, or a
Right.
quantitative
Yeah.
method using aesthesiometer.
Right.
I think that it's important to always check for it. And, considering I work in a very high volume practice where we have technicians that are oftentimes screening our patients, it's educating our staff to also understand the necessity to check for it and then to avoid anesthetics
Right.
when we're suspicious of neurotrophic keratopathy. And that's where really detailing a thorough history and an interview of the patient, and of course, involving a very good clinical exam, including all your dyes, be it fluorescein or lissamine or rose bengal. And then ultimately using all this data, once you diagnose it, implementing, our grading classification system, documenting, and then thinking about our management
Yeah.
strategies. But the key here is the earlier you screen, the faster you can treat the condition and prevent it from progressing down into the later stages of NK.
Well, wonderful. Thank you so much for all of your insights today, Dr. DeBay. And thank you for listening or watching. We will see you next time.